Infliximab is a monoclonal antibody used as therapy, so as a therapeutic, and that's used to treat several inflammatory disorders, including rheumatoid arthritis, inflammatory bowel disease like Crohn's, or ulcerative colitis. And so the assay that we're developing will measure the concentration of this monoclonal antibody or this drug in serum of patients undergoing therapy. We start the Infliximab testing by measuring the Infliximab drug concentration. We use a mass spectrometry approach for that, which is a novel approach in the market. We use a trypsin digestion step, so we cleave all peptides or all proteins in the human serum to generate peptides, and then we're looking for unique peptides to Infliximab in patient serum. When that concentration is low, then that's when we reflex or we add an additional test to look for antibodies to Infliximab. So a couple of reasons why we decided to go with a two-tiered approach for the measurement of Infliximab were one, test utilization strategy, because during the development of this assay, we did several internal studies at Mayo, and we only found clinically significant antibodies to Infliximab in patients that had very low trough concentrations of Infliximab in their serum. So all those patients were considered in partial response, or they had lost complete response to the drug and the drug was not working anymore. So that's why we decided to go with the reflex approach. In that scenario, then antibodies to Infliximab will only be performed when they are clinically relevant, when they are needed, and there's also a cost savings initiative that would benefit patients and healthcare institutions there as well. Also, in the reflex approach that we are offering for Infliximab testing here at Mayo, we provide guidance or we recommend the time frame in treatment on where to test for these patients. Because Infliximab is an intravenous drug, there's no question on compliance, but we want to know to evaluate response. So the trough measurement, or immediately before the next infusion for the patient, is the best informative situation for the patients to measure or to have Infliximab concentrations drawn, so clinicians can make informed decisions on that. The proper situations where Infliximab measurement should be ordered are in the setting of loss of response. So a lot of patients may have inflammatory flares, or they may have flares of the disease, or they may stop responding to treatment after they have been on it for a while. And in those situations, the clinician might want to adjust the therapy or to reduce the infusion intervals, and therefore measurement of Infliximab concentrations would be adequate and would help in making those clinical decisions for patients. So when Infliximab concentrations are low in the bloodstream, then that could be a sign that patients are losing response to therapy. And when that is the case, one of the reasons for loss of response is the appearance of antibodies to Infliximab, or what we call immunogenicity. So a lot of patients may find that Infliximab is a foreign compound and they may develop an immune response to it, and that's what antibodies to Infliximab are. So they would be an immune response of our organism to the drug, and when that happens, then we have an immune complex formation with antibodies to Infliximab binding to Infliximab, and that complex is cleared out of circulation very fast, explaining some of the loss of response that the patient may be experiencing. The clinical practice has shown us, at least in our own institution, that patients that have a very low trough concentration of Infliximab and no detectable antibodies to Infliximab, they may benefit from an adjusted dose, or an increased dose of the drug, or have infusions more frequently. And if patients have then low Infliximab concentrations, but they have presence of antibodies to Infliximab, the clinician might consider switching them off or discontinuing Infliximab treatment and reassessing what would be the best alternative therapy for this patient, or they may decide to add an immunomodulator to therapy. So the scenarios are very variable, and the clinician will have one more piece of information or two more pieces of information to make their decision on how to change the patient care or how to manage the therapy for these patients.